talking about monoclonal antibodies, I just want to mention this briefly because we have other speakers. Monoclonal antibodies have been very important for the treatment of patients with chronic leukemia. They've really been a game changer because with the advent of monoclonal antibodies, we can really say with assuredness that survival of patients is improved. And so that's really very important. The monoclonal antibodies is cartoons, it's like SpongeBob, whatever. But it's a protein. It's a protein that we have in our blood. These are antibody proteins, and then we typically make those antibody proteins when we are infected with a virus or with a bacteria. And these antibodies are very helpful because they can bind to the bacteria, target that bacteria for immune destruction. And the reason that we have the use of IVIG, giving intravenous immunoglobulins, because you get immunoglobulins from other people that can have these protective capacities to bind these other bacteria or viruses. Now, the ability to engineer antibodies is very critical, and we now have the capacity to make and select for the right type of antibody that binds to a given protein or given specificity. And we can make large quantities of that antibody, so you're getting a single type of antibody. That's why it's called monoclonal antibody. And the monoclonal antibody then can be given, and I showed the slide earlier, which is just the slide of all the different proteins on leukemia cells. And we know that B cells are actually somewhat dispensable. We make 100 million B cells every day, and usually they're grist for the mill, because if they don't make the right antibody, they're usually tossed aside, and we make new B cells all the time. Well, a lot of the proteins that are being targeted by antibodies are shown here, and the ones in red are in particular like CD52, which is the target for Campash or alatuzumab, and then CD20 is the target of rituximab, and more recently other monoclonal antibodies too. But you can see that there's a host of other targets that can be used to develop antibodies against. And these could be also improved in various ways. This is the CD20 target, which has been very successful. This is rituximab, and then there's two other approved agents, ofatumumab and obinutuzumab, or Gazyva. And there's several others that may be in clinical testing. It's a very small protein on the surface, and you see these antibodies can bind to various sites of this, so it's very specific and very targeted. Now, there have been some attempts to improve upon how antibodies work. And antibodies usually are being made that can target the leukemia cell for immune destruction, which is to say the antibody binds to the tumor cell, and then T cells and NK cells see that cell, and they say, aha, I've got to destroy that cell. That's how they work. And you can genetically engineer those antibodies. This is the obinutuzumab, and one of our patients called this rituximab with an attitude, because it seems to be very striking. It's been engineered to really be very effective at recruiting those T cells and NK cells to go after the tumor cells. And we've seen actually very dramatic responses where patients can drop their leukemia counts from 80,000 to less than 800 just overnight. So it can be very dramatic. And we have to be careful about watching for what Dr. Choi just mentioned about tumor lysis. We have to be careful with this. I think the first infusion of the antibody typically is the one we find most problematic because patients can have what we call infusion reactions. I remember the first time we treated a patient, I think in the United States here, the patient had a dramatic response with the dropping of her counts, and the nurses actually almost had a revolt. They had a meeting with me and said, Dr. Kipps, we don't want to treat your patients anymore with this antibody unless their patient is hospitalized. And I said, well, we should work out a way to make the antibody administration safer and easier. And so we did by understanding how to give it slowly with other concomitant medications. And now I see the nurses are doing such a good job of giving it to patients even on the weekends. So it's actually a testament to how far you can come. If you understand how to use the right tool, it's sort of like a Ferrari. If you put that in the hands of a teenager, you'd have a wreck. But if you put it in the hands of a skilled driver, you can go and win a race. So I think it's very important for that aspect. Now, obviously, we have many different targets, and there are many different antibodies waiting in the wings. And I think that these antibodies generally are working, as I mentioned to you, to try and target the leukemia cell for immune destruction. But there's some other antibodies that may target very important molecules, and Dr. Griffin mentioned some of these, some of the antibodies that target immune checkpoints that put a brake on the immune system are listed here, and they're going to be tested in clinical trials. And there's also antibody, which was mentioned briefly, this antibody against this ROR1. Most of these proteins here are developmental proteins that are expressed in all B cells. And the reason we're very excited about the ROR1, it seems to be expressed on embryonic cells. It's a protein that we use when we're in embryo, and then as we become mature fetuses, we actually lose the need for that protein, and so therefore it's not expressed on other tissues. So this may allow us to have a greater specificity in targeting the leukemia and not affect, hopefully, the normal B cells. Now, in the interest of time, I think I will stop here because I have some other speakers coming on, I believe. So I want to thank you, and I'll field additional questions, perhaps, in the panel. Thank you.